Let's understand the step-by-step process of how bacteria cause acute pyogenic meningitis. First, bacteria enter the body, usually through the respiratory tract. They then establish localized infection in the nasopharynx. Next comes the critical step. Bacteria invade the bloodstream, creating bacteremia. From the blood, they must cross the blood-brain barrier, a highly selective protective membrane. Once across, bacteria infect the meninges and multiply rapidly in the subarachnoid space, the fluid-filled area surrounding the brain. This multiplication triggers the release of inflammatory mediators, chemicals that cause the classic symptoms: fever, severe headache, neck stiffness, and altered consciousness. Understanding this sequence helps us grasp why early antibiotic treatment is crucial. We need to stop the process before irreversible brain damage occurs. Bacteria enter through the respiratory tract, establish nasopharyngeal colonization, then invade the bloodstream, bacteremia. They cross the blood-brain barrier and multiply in the subarachnoid space, triggering immune system activation. Critical consequences follow through cytokine production, increased BBB permeability, matrix metalloproteinases, MMPs, and nitric oxide, NO, are released, breaking down the BBB and allowing more pathogens and inflammatory cells to enter. Altered cerebral blood flow. Cytokines cause vasodilation and decreased perfusion pressure, leading to ischemia, reduced oxygen delivery to brain tissue. Leukocyte adhesion to capillary endothelium. Increased expression of binding proteins causes white blood cells to stick to vessel walls, obstructing blood flow and worsening ischemia. Reactive oxygen species, ROS production. Both immune cells and damaged endothelial cells release toxic oxygen radicals, causing direct neuronal injury. These processes lead to changes in CSF flow and composition, neuronal damage, increased intracranial pressure, ICP, and cerebral edema, brain swelling. Together, these produce the clinical presentation: fever, severe headache, neck stiffness, altered consciousness, and potentially seizures or coma. Without prompt antibiotic treatment, irreversible brain damage or death occurs. Streptococcus agalactiae, commonly called Group B streptococcus, or GBS, is the leading cause of neonatal meningitis. Let's examine its key features. Microscopically, it appears as gram-positive cocci arranged in chains. It's encapsulated. This capsule helps it evade immune defenses. The cell wall antigen allows us to classify different strep types, hence the name Group B. Newborns become infected during passage through the birth canal. The organism colonizes the maternal vagina, and babies get contaminated during delivery, leading to neonatal septicemia and meningitis, typically within the first week of life. Laboratory identification is straightforward. It's catalase negative, shows beta hemolysis on blood agar, and is CAMP test positive, a key distinguishing feature. Prevention is crucial. We screen pregnant women and treat colonized mothers with intrapartum antibiotics, dramatically reducing neonatal infection rates. E. coli K1 is the second most common cause of neonatal meningitis, after Group B strep. Let's understand what makes this strain special. It's a gram-negative bacillus that's motile and produces lactose-fermenting colonies on MacConkey agar, turning the medium pink. The K1 designation refers to a specific capsular serotype, particularly associated with meningitis. How do babies get infected? E. coli is part of normal maternal fecal flora. During delivery, vaginal contamination with fecal organisms leads to colonization of the newborn. In vulnerable neonates, this can progress to septicemia and meningitis. Two key virulence factors make K1 dangerous. The K1 capsule helps it evade phagocytosis and survive in blood, while endotoxin, part of its gram-negative cell wall, triggers shock and massive inflammation. Neisseria meningitidis is a gram-negative diplococcus armed with virulence factors. A polysaccharide capsule resists phagocytosis. IgA protease destroys mucosal antibodies. Endotoxin causes shock, and pili enable attachment to respiratory mucosa. Laboratory identification. It's oxidase positive and uniquely ferments maltose. Transmission occurs through respiratory droplets in crowded settings like dormitories and military barracks. Clinically, it causes abrupt onset of fever, chills, malaise, and characteristic petechial rash, small hemorrhagic spots on the skin caused by vascular damage from endotoxin. Prevention involves two strategies: immunoprophylaxis through vaccination, and giving rifampicin to close contacts to eliminate nasopharyngeal carriage and prevent secondary cases. Let's analyze this clinical case. A 42-year-old HIV-positive man presents with severe, worsening headache over 2 days and inability to move his neck. He also has 1 week of diarrhea following a wine tasting festival. Think food exposure. On examination, temperature is normal at 37 degrees. He's oriented, vital signs are stable, and surprisingly, Brudzinski's and Koenig's signs are negative. What's unusual here? Classic bacterial meningitis typically presents with fever and positive meningeal signs. This patient has neither. His HIV status tells us he's immunocompromised, and the food history is a crucial clue. What organism fits this profile? We'll reveal the answer on the next slide. The answer to our case is Listeria monocytogenes, a unique bacterium with fascinating characteristics. Morphologically, it's a small gram-positive rod with a distinctive tumbling motility in liquid medium. It's an intracellular parasite, meaning it lives inside host cells. On blood agar, it shows beta hemolysis. Remarkably, it grows at refrigerator temperatures, 4 degrees Celsius, which is why refrigeration doesn't protect against it. Transmission occurs through contaminated food, soft cheeses, deli meats, coleslaw, and unpasteurized products. Pregnant women can also transmit it to babies during delivery. Its key virulence factor is Listeriolysin O, a hemolysin that helps it escape from phagosomes and evade destruction by immune cells. Clinically, Listeria causes meningitis primarily in 2 populations: immunocompromised patients, especially those with suppressed T-cell immunity like our HIV patient, and transplant recipients on immunosuppressive therapy. This explains our case perfectly. HIV patient, food exposure at the festival, meningitis without typical findings. Always consider Listeria in immunocompromised patients with meningitis. Finally, let's discuss Haemophilus influenzae. Despite its name, it doesn't cause influenza but was historically a major cause of childhood meningitis. It's a gram-negative coccobacillus with pleomorphic appearance, variable shapes. Type B strains are encapsulated and produce IgA protease and outer membrane proteins, all virulence factors. Laboratory culture requires special conditions. It's fastidious, needing X factor hemin and V factor NAD for growth. We use chocolate agar, which provides both. A classic test is the satellite phenomenon. When grown near Staphylococcus aureus on blood agar, H. influenzae grows in a ring around the staph colonies because staph releases the V factor. Transmission occurs through respiratory droplets and fomites. For rapid diagnosis, we use latex agglutination to detect capsular antigen directly in cerebrospinal fluid. The game changer has been the HIV vaccine dramatically reduced childhood meningitis cases, making it much less common today. Today, we're meeting a 72-year-old woman with a truly concerning presentation. Her son brings her to the ED because, over the last 24 hours, she's been having jerky movements of her hands and legs, crucially, without losing consciousness, and she's becoming increasingly drowsy. This follows 3 days of a high fever and escalating confusion. Her son noticed something else, a strange sensitivity to light. She'd pulled all her house curtains and complained of a bad headache in bright conditions. No major health issues in her history, making this all the more alarming. On examination, she's running a temperature of 38.2 carat circ-text $C and is completely disoriented. Her chest exam reveals crepitations, a crackling sound, at the base of her left lung. The key neurological finding? A positive Brudzinski sign, where flexing her neck causes her hips and knees to involuntarily flex. This triad of fever, confusion, and meningeal signs points our investigation in one critical direction. The culprit here is almost certainly Streptococcus pneumonia. It is a gram-positive coccus that typically grows in pairs. On a blood agar plate, they exhibit alpha hemolysis. It's transmitted by respiratory droplets, commonly colonizing the nasopharynx without causing immediate disease. But if conditions are right, or if the host is weakened, it can invade. Its main virulence factors are its protective capsule and an IgA protease that breaks down one of our key mucosal antibodies. The case's lung crepitations suggest it likely started as a pneumonia before crossing the blood-brain barrier. Conditions like a recent flu infection, COPD, or alcoholism are common predisposing factors. To confirm the diagnosis, we look at the CSF, which shows a high white cell count, and, crucially, low glucose, as the bacteria is rapidly consuming it. Quick identification can be done with the Quellung reaction or a latex agglutination test for the capsular antigen.